Good afternoon, everybody. Thank you indeed very much for taking the time off on Saturday afternoon to come to this launch of the cancer screening site. You know, to those of us who are doing some of these things in the name of national service, sometimes we wonder whether it's worth the effort. But to see so many of you, who are interested to take a Saturday off to come, and hopefully with these guidelines to be able to improve just a little bit knowledge and standards in clinical practice, I think that would be time well spent and it would be worth our while. I'll just, by way of introduction, go through some of the principles regarding screening because I think that's important for us to bear in mind. So those of you who are familiar with some of these principles, I beg your indulgence because I may be going through some of the points that you already know, but certainly it would be good for us to refresh in our memories some of these important points to bear in mind. There's always a very strong intuitive appeal for screening in general because if you go out there and you screen enough people, no matter what the disease is, invariably you will detect some early cases. And of course, when some of these patients turn up for treatment at the early stage, of course we get good results. And in the process, we save some lives. So there's always a very strong appeal for screening. And unfortunately, sometimes we have to bear in mind that, well, even though you may find disease, but the situation is not as ideal as we would like it to be. In the ideal situation, you can actually separate the abnormal from the normal in a very clear-cut fashion like this. And you say, well, okay, if we can screen and pick out all those cases that are in the abnormal category, then you treat them, well, fantastic, you get good results. Unfortunately, the reality is something like this. When you have the overlap between those who are abnormal and those who are normal. And that's where it becomes a challenge. Because in reality, we have situations when some patients will be detected truly, and these are what we call the true positives. Unfortunately, there will be some who don't have the disease, but nevertheless are found positive by the test. And so these are the false positives. Similarly, so in a real life situation like this, we want to minimize as much as possible the false positives and the false negatives. The false positives, as you know very well, they'll be subjected to a lot of unnecessary investigations. Some of them may even be treated. And of course, a lot of anxiety. They tell this woman, you may have breast cancer because there's some shadows on the mammogram. She goes home, she can't eat, she can't sleep because, this thing is hanging over her head. And it doesn't help that 1 week later, a few days later, she goes back and says, well, okay, you're negative. The tests all show that you're negative. These are the unfortunate consequences of a false positive. But what about the false negatives? False negatives, well, they'll have a false sense of security. 6 months later, they have symptoms, and then they go and see the doctor and say, well, I was found negative, but how come I have these symptoms? The doctor checks, and all of you, I'm sure, have seen such cases. Turn out that he or she has the disease. And these are, of course, very unfortunate circumstances, but we know for sure they do happen. In fact, I just had a friend who was found to have breast cancer 6 months after she was told that it was negative and clear. So to some extent, well, they are losers, and they are losers not because they went to seek medical attention because they're ill, but because they were told to come for screening. So that's the challenge in screening because you are actually dealing with normal, apparently normal, healthy. There are other issues. I won't go into details on these issues because, it's a bit technical. Certainly just to bear in mind that there is such a thing called a lead time bias. In other words, when you look at this diagram here, you can see that if you depend on onset of symptoms, the diagnosis will take place within a reasonable period of time if the patient were to seek medical attention. If you do a screen, you may be able to detect the cancer earlier, so the diagnosis is made earlier. But in terms of the outcome, in this case measured by death, it's exactly the same. So when you look at a situation like this, you say that, there is a longer period of survival, but actually that's not true because the patient will still die at whatever the age is, 60 or 65 or 70. But the diagnosis is made earlier because of the screening test. So it gives us a false sense of security that we have done some good for the patient. Actually, we haven't. So that's what we mean by lead time bias. It does occur, and it's been estimated for some cancers because we don't have the full knowledge about the natural history of the disease. Can be as long as 1 year or even more, in terms of the lead time bias. And of course, the other one is referred to as length bias. In other words, the length of the growth, the duration of growth of the tumor. In screening, we tend to pick up the tumors that are slow growing. So in other words, there's a long length period duration acceleration of growth. And obviously, if you're slow growing, then chances of being picked up will be faster and much better. Whereas a fast-growing tumor, if it occurs and it starts to spread within 6 months, you would have missed any screening test. So you're picking up all the slow-growing tumors. And of course, the big question then comes is, well, I mean, are we doing any good? So these are some of the challenges. I'm not saying that screening is no good. Of course, later on, our experts will tell you that, screening does have a very big role to play. But we must be aware of some of these issues and challenges. Okay, that's all I'm saying. So we need a very balanced view to know that, well, screening is what we refer to as a presumptive diagnosis. In other words, it gives us an idea whether the patients may or may not have the disease. It is not a definitive diagnosis. Okay, so that's the difference. So once you find that a test is found to be positive, what it means is that there's an indication for further investigation. You certainly do not treat anybody on the basis of a screening test. You must go on for further investigations to confirm the diagnosis, and then only will we institute treatment. Okay? And the gold standard in all screening programs is that we must reduce mortality in a randomized controlled trial. This is the gold standard. So if you can't attain this gold standard, then chances are the evidence will not be that strong. So that's where this clinical practice guidelines comes in, because we will present to you, in fact it's already printed, all the levels of evidence, whether it's evidence A or B or C, to tell you whether the evidence is strong or not so strong or weak with regard to particular cancers, with regard to particular procedures. Okay? And so this is very important that we have these guidelines to guide your practice and decision making and how you would advise your patients. But of course, they are not static, they're not cast in concrete, and we need to review them every now and then to make sure that we keep up to date in terms of our knowledge. So the evidence is there, and you will of course go through them at your own time. Grades B being strong, C, well, we need some further thought, D may be weak, and GPP we refer to as good practice, where we say that it's based on clinical experience, but certainly not based on very strong scientific evidence. But ultimately, these are just guidelines, because you will still have to make your considered clinical judgment, and we respect that. Okay, so there's always a balance between good judgment and the scientific evidence that's available. We are very thankful to the various people who have worked to produce these guidelines, and particularly grateful to the various chairs of the subcommittees. Some of them will be speaking, and at the end of the session, during the Q&A session, the other chairman who may not be speaking but will be available to answer questions. And all these speakers today are very well-known experts in their field, so they really do not need much introduction. Professor Yeo, gastroenterologist; Professor London Wee, who is a well-known surgeon, special interests in hepatology; Dr. James Koo, radiologist, who is known for his work in mammograms and breast cancer screening; Professor Jeffrey Loh, gynecologist, who is going to talk to you about cervical cancer; and Ms. Christine Falk from Health Promotion Board, who will tell us a little bit about their screening program. So that's the program for this afternoon, and we will entertain questions during the Q&A with the other chairman come on board as well. We're also very thankful to DMS for going through all our guidelines, and he actually personally went through all the guidelines and discussed some of these matters with us. All these guidelines also went through the Academy of Medicine and the College of Family Practitioners to make sure that they're all sound and reasonable, so that you're not just being told something that is somebody's personal opinion. And lastly, of course, we want to thank the Secretariat for having done all this great work in getting these guidelines published. And last but not least, our sponsors for the lunch, Olympus. So thank you very much. Yeah.